2023 update and just go through various steps as we go along. I'm going to start out with the potential pharmaceutical disclosures, and frankly, these are all studies I'm involved with in what's called data monitoring, and there are safety aspects that I'm involved with in all of these, but I don't think any of this pertains to what I'm going to speak to today. I do have an editorial disclosure. The Drug Eruption and Reaction Manual, LITS, is something that I am involved with, and I do get a small payment for it, so I just thought I'd mention it because I think it's a really great resource, and people should have it if they want to know what's going on with drug reactions. Something we've been doing over the past couple of years is emphasizing, I guess what we were always doing, but really should focus on, are themes pertinent to diversity, equity, and inclusion in dermatology and medicine. And I have three here that I use in almost all of my presentations because I think they're all important. One is skin of color, which is not represented well in textbooks or even online, and is a challenge in many ways to us doing our best for our patients. And I'll come to that because that does come up in this presentation today. There are also genetic risks for severe drug reactions that are well described. We know these. We know if you have this gene, you can get Stevens-Johnson syndrome, or at least you're at a higher risk. And in some parts of the world, especially Southeast Asia, it's being done to screen patients before they get it. Sadly, it's not being done enough. And the reason it's here is because in terms of diversity, almost all of these genes are in underserviced areas around the world, in the globe. So that's something we need to do. Another issue is about gender and drug reactions. And women are definitely more prone to drug allergy than men. And the studies that we did years and years ago, decades ago, it was always about a 3-to-1 ratio, women to men. Now, there's two things I want to add to that. One is, first, as much as we've done studies on trying to understand this, the best paper I've ever seen is called, and it's listed below, why nearly 80% of autoimmune sufferers are female. And that is really focusing a lot on things like rheumatoid arthritis, et cetera, but also applies to skin disease. And this review went through all of the various reasons why this is occurring. And it goes into all of the medicine and scientific background. Hasn't really changed the way we prescribe completely, but it's important. One thing that's interesting to me is that in some of the cases I'm going to show you today, the reactions are more common in men than women. So different answers for different questions. So my plan and my goals. I want to talk about what I will call hot topics from 2022. And comorbidities, mimics, treatment, and I want to talk about ChatGPT. This is a peek into the future, but this is clearly in the news. I'm sure many of you have heard about this. And I just want to show you a little bit about how it affects what we do in drug reactions and drug safety, as well as other aspects of medical care. You may need to take screenshots to capture all of this because I did not want to have a lot of pictures of the steps that are involved in the reactions. I really want to talk about it from a clinician's perspective. And of course, COVID-19, we can't almost ever talk about anything without mentioning COVID-19. And here's a paper called Association Between COVID-19 Vaccination and Bullous Pemphigoid, a case series and literature review. And you can see a picture in the upper right where there's some blistering, and here's a black skin example. So skin of color issue, and you can see the immunofluorescence, et cetera. And then on the bottom of that is patient, different patient, obviously, elbow with circles of blisters all over, which all on pathology and clinically, and that every criteria being bullous pemphigoid. And I wasn't necessarily going to be talking about bullous pemphigoid, and which I've done quite a bit over the past few years, but bullous pemphigoid keeps pulling me back because there's so much going on in that area. And I want to go through that. So here's their conclusions in this study, which is, it's available online in an open fashion. And they said, in conclusion, new onset bullous pemphigoid may develop following COVID-19 vaccination, which makes sense. You have a stimulus and you stimulate aspects of the immune system. So after ruling out Other potential triggers for bullous pemphigoid, including drugs and other vaccinations. Affected individuals should be monitored closely following subsequent COVID-19 vaccinations. Entering a period of clinical remission before pursuit of subsequent vaccination should be considered to lessen the risk of a worsening cutaneous reaction. In other words, we don't know what to do. And if you look at all of the literature on this, there's no clear answer. Some patients keep getting the vaccination as scheduled, and they're fine. Some patients get a recurrence. We don't know. And do we have any plan to say, well, we need to give you perhaps a mild immune suppressor when we give you the vaccination? Again, we don't know. There's still so much to learn, but we can expect that this doesn't mean you should not get the COVID-19 vaccination. Here's another one. And this one also was quite interesting to me, and that's why I picked it out. There's a huge amount of literature now in case reports, et cetera. But I thought this was important. Heparin-induced bullous hemorrhagic dermatosis. That's a mouthful. Heparin-induced bullous hemorrhagic dermatosis. And it really shows the features of bullous pemphigoid. But what you can see here is blisters, and they tend to be filled with blood because the person is on a heparin. And my summary is in the text on the left that this is a blistering eruption, can happen as early as 4 days after heparin exposure. Didn't matter which type of heparin it was. When you look at all the cases, there aren't a lot of cases, but there are many types of heparin, and it didn't matter which type it was. And it mostly involved extremities. So as you can see on the hand here, but also it can be on the body, but more likely to be on the extremities. But it's important, obviously, to examine the patient completely. Males are more common than females in terms of getting this, and it can resolve spontaneously, but can reoccur. And frankly, there's a lot of discussion in this about, what's going on and all the immune processes. We don't know. We don't know, but you might be called to see somebody who has this kind of hemorrhagic reaction, and now you'll know that you should be looking for heparin as a possible trigger. Heparin-induced bullous hemorrhagic dermatosis. Then there's annular bullous pemphigoid. And I don't think that's got much attention. And there you can see a picture. It's not super clear, but basically this person has areas of erythema with blistering, and the blistering is mostly around in a circle out on the edge of the erythema. This was from a Canadian journal, and Alexandra Morenik was a trainee of mine, and she's done a really good job with your group of putting some of this together. So I wanted to highlight the cases. Now, they have case reports as well as a review of the literature. And so if this is something that comes up, this is a good paper to go to find out more. But I just want to show you more specifically and more clearly what the characteristics were. If you look at the second column, patient characteristics, first one was a male, a 4-year-old. Now, 4-year-olds don't get bullous pemphigoid usually. This is really something. But this is what they saw, that these patients who were getting it were definitely younger than your usual group of the elderly who get bullous pemphigoid. And they met all the criteria, as you could see in the immunologic finding table. The next one was related to a rectal adenocarcinoma. And what happens there is that, of course, cancers and cancer treatments can trigger bullous pemphigoid. And in fact, once the cancer was resected, the bullous pemphigoid went away. The annular bullous pemphigoid went away. And remember, this is all about annular bullous pemphigoid. And then we have some mild oral involvement. Usually oral involvement is not seen. And there were 2 women at the end, but one was 5 months old. One was 64 years old, which you'd expect, but a 5-month-old coming in with a blistering eruption like this, I don't think that a lot of people who see children would necessarily think right away of annular bullous pemphigoid. Getting into the skin of color aspect, and we're doing a lot of projects in Canada right now about getting awareness, especially among trainees in dermatology, and had a challenge to the trainees across the country to write an essay with certain criteria about what they feel about working and seeing skin of color in the clinics that we have, which are quite diverse. And it was a really great project, and the trainees wrote wonderful essays. This one here is from a publication that came out in Clinics of Dermatology in 2022, and it's quite a long paper. If you look at the reference in the bottom right, you'll see there's a lot here. It's basically an atlas, and I think some of the highlights I put in the box that says that skin of color patients are more likely to present at a younger age than we see in lighter skin. And they found that there was a longer time before diagnosis and symptoms all pointed to bullous pemphigoid. Also, erythema cannot be relied upon as much because it's harder to see, and that they were more likely to present with dyspigmentation afterward if their skin was dark. So there are various features, but this is a very nice review. There's very little in this field that's up to date, especially in autoimmune blistering diseases. So I thought this was really a good paper and a good reference to think about if you see that kind of situation, if you want to use it perhaps in teaching. The only other paper that I could find in the past year that addressed specifically skin of color and blistering diseases was this effect of skin color and Fitzpatrick skin type on bullous pemphigoid disease area index. Now, clinically, I don't use a BPDAI, but it is done in clinical trials, which means not only are the photographs racist, but maybe the clinical trials can be perverse and racist, if you will, because it doesn't take into account what might be happening in skin of color. And what they're saying is that this measure that can be used in clinical trials, therefore telling a company that, hey, your drug is doing such and such, might underestimate overall disease severity in patients with darker skin by underrating because of the design of that BPDAI. So the idea was keep your mind open. And I certainly will when I'm looking at clinical trials now in my role as a safety monitor to think about what happened in skin of color in terms of getting these scores and how that score might impact their care. And you can see the references on the upper left, and this is in the British Journal of Dermatology, 2022. Annular bullous diseases. Well, of course, this attracted me if I'm going to be giving a talk on bullous diseases. And it was a huge article. It really is very long. And look at all the diseases that they talk about: bullous pemphigoid, pemphigoid gestationis, epidermolysis bullosa simplex, Dowling-Meara, and immunoglobulin A bullous dermatosis, chronic bullous disease of childhood, etc. So this is just a reference if you're interested in the area of annular bullous diseases. It's really well done, and they're great pictures and discussion. Now, I put this in as a model of some of the studies that are coming. Bullous pemphigoid is hot. We're getting a lot of studies coming. And this was a open label study almost in early phase 2A. So it's a very early development, but basically the idea was, can we see if this C5 and leukotriene B4 inhibitor can have an effect in treating bullous pemphigoid? And the answer was, yes, it looks like it does. So it doesn't really matter. The point is that there's going to be more studies coming, more at this level and more new ones coming, and there may be many different targets for managing bullous pemphigoid. Now, I can't talk about this without, of course, one of my favorite things that totally changed my life was the dipeptidyl peptidase 4 inhibitor-related bullous pemphigoid. Basically, people who are getting, therapy for and when patients get exposed to this for their diabetes, they can get bullous pemphigoid, but it isn't noted. And I've seen that too many times. You have to go back and look at every patient chronically who's on an immunosuppressant or anti-inflammatory therapy because of bullous pemphigoid, and also are diabetics who might be triggered by being on these drugs. And so that's really important, and it hasn't gone away. It is something to basically look back retrospectively to make sure that even if you're inheriting a patient, what drugs are they on? If they're still on a drug in this category, then maybe their bullous pemphigoid could be cured. Sometimes you stop it and it doesn't get better, and so it's not always a cause, but it's important. Also, what's new in the pathogenesis of triggering factors of bullous pemphigoid? I just put this in as an unbelievably beautiful review. If you're giving a talk on bullous pemphigoid to trainees and you want to show lots of color diagrams that show all the different aspects of where all the interactions are going on, this in the Journal of Dermatology is just a beautiful, beautiful, thoughtful presentation, and it deserves, you know, a longer period than just a quick presentation today. So peeking into the world of artificial intelligence is more than autocorrect. The utility of machine learning is a reality. It's happening now and affects all fields, sciences, technology, pick anything, and dermatology is no exception. Chat GPT is the most up-to-date one now. And just so you know, chat because you're talking to it, and GPT because it's a generative pre-trained transformer. I want to thank Trevor Champagne, who's a colleague of mine and a former trainee, who is a computer genius. And just watching him work with this is just so exciting because it makes things that were complicated so easy. So how does it affect here? Here's what I asked the machine. I spoke to the machine and I said, if I were giving a presentation on autoimmune bullous diseases to dermatologists in Canada, what controversial topics should I discuss? Imagine if I asked you that. It immediately replied, there are several controversial topics that you may wish to want to discuss in a presentation on autoimmune blistering diseases. Well, it sounds like maybe they're avoiding the question, but no. Some possible topics include, and this is just the top half of a long answer. It actually shows up on the computer screen in paragraphs, but this is the way we could capture it. And what you see is it broke it down into 5 categories. Diagnosis, and if you look on the right, I can show you what those categories or domains are. Diagnosis does not talk about causality. I really think we look at the steps of diagnosis immediately, then followed by causality. Nevertheless, treatment, patient adherence, I would not have thought of that, economic and ethical considerations. Very, very thoughtful. And the point is, while it does have a discussion about what different dermatologists might do, which is where the blue arrows on the left are talking about, if you look at the blue arrow on the right, there is no single answer, which is great. It's meant to be a discussion. And I will tell you, when I say it comes up instantly, it does come up instantly. It just starts typing right in front of you. So the learning objectives today was there's a wide type and variation of blistering diseases in the skin. Bullous pemphigoid variants are very popular now in the literature, case reports here and there, and anything from psoriasis to almost any other immune disease can be seen with bullous pemphigoid. But remember the steps: diagnosis and then causality assessment. Was it a drug, an infection, a vaccine? You know, what else triggered this so you can make a good decision in the future? And what will the role of AI be in the very near future? I think it's going to change how we teach. It's going to change how we evaluate situations and exams in real life, etc. But we'll see. But it really is very exciting, and it's happening now. Thank you very much for this opportunity, and I hope you have a wonderful meeting.
Thank you, Professor Neil.